Welcome to the 2025 MedFit Education Foundation webinar series. We are kicking off our webinar year with Carla DiGirolamo, and her topic is hormone therapy, where we've been and where we're going. I'm Jonathan Ross, your host and Director of Education and author of our Alzheimer's and Brain Fitness course. Let's meet Carla virtually, and then you'll have a chance to meet her in person as she begins her session today. Carla is a double board certified obstetrician, gynecologist, and reproductive endocrinologist specializing in the care of reproductive age and midlife women. She's a North American Menopause Society certified menopause practitioner. She's a CrossFit Level 1 trainer, certified nutrition coach, Les Mills Body Combat and Body Pump Group Fitness instructor, and she's been named to Boston Magazine's top doctors list in the Boston area for 2019 to 2024. And she recently launched a telehealth practice specializing in the reproductive endocrine care for active and high-performing women from puberty through menopause. And previously, she was a partner at Boston IVF in Waltham, Massachusetts. I'm going to turn it over to Carla. And so, Carla, you can get ready to start your screen share, and I'll get ready to turn mine off. And take over. Here we go. Stop sharing on my end. You can start on yours. There we go.
Hey, and thank you, Jonathan, for the wonderful introduction. And thank you to Lisa Doherty for inviting me to do this talk today. Excellent. Well, thank you again, everybody, for joining in today and for your attention. And when I created the Menopause Fitness Specialist course, I did not include a section on hormone therapy because at the time, my thinking was that there was just so much to talk about with respect to the menopausal experience, physiology, training, and nutrition that, you know, if fitness professionals aren't prescribing the medication, then maybe that is lower on the priority list. But I have to say, since then, it's come to my attention from clients that I've seen and from fitness professionals whom I work with is that they are being asked about hormone therapy all the time. And they're having these conversations because patients are very frustrated with the medical community in their lack of knowledge, and they're just not being heard. And so what it's turned into is that the fitness professional has been the frontline person fielding these questions. And so what I was hoping to provide today are some materials for you all to refer back to just be able to have a conversation with clients about hormone therapy and point them in the right direction to get the care they need. So I'm hoping I can accomplish that goal today. So with that, these are my disclosures. I have no financial conflicts of interest today, and I am not being compensated for this talk. So we're going to take a trip back in time, and it's often very helpful to watch a field like hormone therapy kind of unfold in a chronological sort of way. Because when you take a step back and you see the big picture, it tells a story. And there's a lot of perspective that can be gained by following that story. And I'm hoping that we can gain that perspective together as I go through this information and that this will all make sense. So we're basically going to start with how hormone therapy started, and we're going to go through how the data has evolved, how the recommendations from the major society have evolved, and what's coming down the pike on the horizon. So in 1942, World War II era, the FDA approved Premarin by Wyeth for the treatment of menopausal symptoms. Premarin was conjugated equine estrogen. This is estrogens, different types of estrogens that were purified from horse urine. And so this is what was FDA approved back then. It was purified, of course. In 1966, Robert A. Wilson published Feminine Forever. And the sentiment at the time was that menopause is a hormone deficiency disease, curable and totally preventable by just taking estrogen. In the 1970s, we learned that estrogen use was associated with the development of endometrial cancer. And so what emerged at this time was the use of progesterone in women with an intact uterus to help to prevent the development of endometrial cancer. In 1988, the FDA approved hormone therapy for osteoporosis prevention. and the American College of Physicians released guidelines for hormone therapy use for prevention of chronic disease. In the 90s, the first randomized controlled trials for hormone therapy began. The HERS trial began in 1993, and that was looking at hormone therapy for the prevention of cardiovascular disease. And of course, the Women's Health Initiative study, which was initiated in 1991, looking at hormone therapy in prevention of various other endpoints, cardiovascular disease, osteoporosis, various types of cancers. In 2002, about 10 to 12 years later, the Women's Health Initiative study staff terminated the estrogen progesterone arm of the study because the incidence of breast cancer exceeded their safety thresholds, which were set out in the study guidelines. And so the frequency of breast cancers exceeded this, and so they stopped that arm of the study. And so what that resulted in, because of the interpretation of this data, because of the media messaging surrounding this data, this resulted in a rapid and widespread decline in the use of hormone therapy and in the prescribing practices of physicians. Everybody was afraid to take it, and everybody was afraid to prescribe it. And sadly, those apprehensions still exist today. In 2010 and 2012, the North American Menopause Society issued their first position statement on hormone therapy. 5 years later, they did an updated one in 2017, which was about twice the size of the first one. In 2018, Estrogen Matters, the famous book by Avram Blooming and Carol Tavris, was published, and this basically really called to the carpet the messaging and the interpretation of these studies. And this was a landmark publication that really turned the tides of the direction of the research, because it called the initial interpretations into question, and rightfully so. In 2022, the Royal College of OBGYNs and the British Menopause Society issued a joint position statement on hormone therapy use because of some practices that were considered non-traditional that were occurring in the UK. And so they came out with a joint position statement. And then shortly after that, that same year, the North American Menopause Society again updated their position statement on hormone therapy. Now, in my blog, Athletic Aging, I actually summarized this joint position statement. So if you wanted to check that out and learn more about it, you can go to athleticaging.blog and just search for hormone therapy. You should be able to find it. So what we're going to do now is we're going to take a look at the position statements. And what the position statements were is a summary of all of the research done to date by a special task force of scientists and clinicians who were experts in the field to collect and interpret the data and issue recommendations based on the data at that time. And so we're going to go through each one, and we're going to watch the whole story unfold. So the very first one was in 2010, 2012. And so some of the high points of this position statement were that individualization according to risk, benefits, and symptoms and impact on quality of life is essential. Every woman is different, and the approach needs to be individualized for her circumstances. Low risk candidates for hormone therapy are women less than the age of 60 within the first 10 years of menopause onset. And at that time, because of the Women's Health Initiative data, they were recommending limits on the duration of estrogen and progesterone therapy, which was 3 to 5 years, and estrogen alone therapy for 4 to 7 years. Estrogen alone is usually for women who do not have an intact uterus. They've had a hysterectomy. So that was a different risk group, surprisingly. So that's why those numbers are different. And it all had to do with the risk of breast cancer, why those numbers are different. And so the sentiment at the time was give the lowest possible dose for the shortest period of time. Specifically regarding hot flashes, otherwise known as vasomotor symptoms, estrogen and estrogen progesterone therapy are the most effective treatment for this symptom. and progestogen, which is a blanket umbrella term we use for synthetic progestins like levonorgestrel, medroxyprogesterone acetate, as well as bioidentical progesterone, which is micronized progesterone. That's just a blanket term for those. Using just a progestogen is also effective for relieving vasomotor symptoms, but it's not quite as effective as estrogen-based therapies. With respect to cardiovascular disease and stroke, what was emerging at that time was the timing of hormone therapy initiation was critical. Within the first 10 years of menopause under the age of 60, they found that treating symptomatic women resulted in a lower risk of coronary heart disease. And when we initiated hormone therapy after 10 years beyond the onset of menopause in older women over 60, we actually found an increased risk of coronary heart disease. Also, at that time, consensus was that if you can use transdermal preparations, meaning like patches and sprays through the skin, those can potentially be safer with respect to blood clot risk than the oral preparations. Bone health. There was a lot of data at that time that was emerging saying that there was a reduction in postmenopausal osteoporotic fracture risk in the hip and spine in women who were taking hormone therapy. And what was also observed is that the benefits of hormone therapy on bone health rapidly deteriorate after hormone therapy is discontinued. Hormone therapy is not approved for the treatment of osteoporosis. These studies were more done looking at the prevention of osteoporosis and fractures. And at that time, there was the notion that, you know what, if you've got somebody with super high risk of a fracture, maybe extending the use of hormone therapy would be considered beyond those 3 to 5, 4 to 7 year guidelines that were out at the time, because fracture risk is such a major cause of morbidity and mortality. So that was the first time we started thinking about, well, it might be okay to extend the use of these medications. And what was also emerging at the time is that ultra low doses of estrogen were even able to impart bone benefits. So what happened at that point in time, I remember I was in residency at this time, these new preparations of these ultra low dose patches and pills were coming on the market because you could use just a very, very low dose and still get those bone benefits. In terms of vaginal and urinary health, hormone therapy is the most effective treatment for vaginal dryness and painful sex. Progesterone is not needed with low-dose vaginal estrogen because the estrogen is not absorbed into the circulation to any appreciable extent. So you don't have that risk of exposure to the uterus. So you don't need progesterone for that. And they were saying that back in 2012. Hormone therapy is not recommended for the sole treatment of sexual dysfunction or low libido. And the vaginal form of estrogen therapy may be beneficial in some women with overactive bladder. So this was emerging in 2012. Premature menopause, this is a separate medical entity. Women who go through menopause, whether it be naturally or surgically before the age of 40, are in a completely different risk group. It's a different medical group. And hormone therapy is considered the standard of care. Pretty universally, people are recommended to go on this for bone protection, cardiovascular protection, and cognitive functioning protection. And this is when this was emerging that, yeah, this is the standard of care. This is what we need to do for these women who lose their cycles so early in life. And the recommendations at the time were to continue these therapies. Usually it was birth control pills. That's what we'd usually give to young women. We'd give them up until the age of natural menopause, around early 50s, and then you could just transition them directly into menopausal dosed hormone therapy. So this notion was also emerging in 2012. They were starting to look at diabetes. There was reliable evidence at that time that hormone therapy reduces new onset type 2 diabetes. The data surrounding cognitive aging and dementia at that time was mixed, and it still is. This is still a very hot topic of debate 20 years later. In younger women, mixed results about whether hormone therapy could help or not, but there did tend to be a trend toward a detrimental impact in older women. But again, the jury's still out on this, and it is still a subject of debate. Depression, hormone therapy impact on depressive symptoms, still very mixed results even today, but in 2012 is when they just started looking at these things. So at that time, the FDA-approved indications for hormone therapy were hot flashes and prevention of osteoporosis. Now, 2017, 5 years later, North American Menopause Society issued a new position statement. And like I mentioned before, it was twice as long as the first one. And so there was a lot of work being done to try to answer a lot of the questions that were raised by the Women's Health Initiative and the HERS studies and many of the other studies going on at the time. So there was more information about many, many different topics. There was at this time now greater appreciation that the formulation of hormone therapy, the dose and the way we give it, whether it's a patch or a pill, had different effects. In the Women's Health Initiative trial, they used Premarin and Prempro. Those are formulations we almost never use anymore, and we really weren't using them in 2017 either. And that was the reason why they wanted to start looking at other formulations. Were they different? And could you extrapolate the results from the Women's Health Initiative study using oral medications to people who are using patches and sprays, et cetera? And what they found out is that, yeah, there's some differences for sure. Additional areas of study emerged, like effects of hormone therapy on joint pain, gallbladder disease, skin, hair, and nails, and sarcopenia. Very, very important for us as fitness professionals to be aware of sarcopenia in our aging population. There was a continued expansion of knowledge on cardiovascular disease risk and also risks of hormone therapy in cancer survivors, particularly breast cancer. At this point, they started acknowledging that body composition changes, maybe we should study this, which is, almost kind of comical because as fitness professionals, that's like the number one reason people come see us is because, oh my God, I've got belly fat. And it's huge. And unfortunately, the medical community just was starting to acknowledge this in 2017. And then the other sentiment that was emerging was this movement away from the lowest possible dose, shortest period of time to appropriate dose, duration, regimen, and route of administration. And I think this was because the more study that was done, it was becoming more clear who was at greater risk and who was this safe for. This was becoming more clear. And I think there was a greater comfort zone surrounding prescribing hormone therapy for various groups. And so they started to relax this, oh my God, just take the smallest amount you need and then get off it as soon as you can sort of perspective. So we learned a lot more in the 2017 position statement about genitourinary syndrome of menopause, or GSM. And this basically encompasses discomfort in the external genitalia, urinary tract issues and incontinence, pelvic floor disorders, sexual symptoms. Again, they reaffirmed what we knew in 2012 about low-dose intravaginal estrogen therapy, that there's minimal to no systemic absorption. Still don't need progesterone for it. And there were new formulations being developed for painful intercourse, like DHEA. Progesterone is an FDA-approved DHEA therapy for painful sex. And so these other non-hormonal agents were emerging for symptom management. Breast cancer risk and hormone therapy in breast cancer survivors. In 2017, they were really looking hard at this and trying to better stratify risk of who hormone therapy was safe for and who wasn't based on breast cancer risk. So what we learned at this point was that a family history of breast cancer imparts no additional risk of developing breast cancer on hormone therapy. There's limited evidence at that time that hormone therapy use in BRCA positive women, these are women who carry the BRCA gene, which has a very high chance of developing breast cancer. People have prophylactic surgery and mastectomies for this if they carry this gene. But women, even those women who carry these high-risk genes, if they've never had a personal breast cancer history, those women were at no increased risk of developing breast cancer. Low-dose vaginal estrogen treatment for GSM may be considered in breast cancer survivors, again, because we knew since 2012 that the estrogen is minimally absorbed when used vaginally. So people were kind of relaxing about using that in breast cancer survivors. And the effect of hormone therapy on breast cancer risk may differ relative to the formulation of hormone therapy, the dose, the route, and the duration of treatment. Now, still in 2017, it was still considered nearly an absolute contraindication for someone with a personal history of breast cancer to have systemic, meaning not vaginal, but systemic hormone therapy. And this is changing, thankfully, and we're going to go over some really cool data toward the end, but this is how they felt in 2017. It still was considered something that we don't do. With respect to cardiovascular disease risk, there were greater markers in many of the studies that they used. They were looking at coronary artery calcium score and coronary artery intimal thickness to better stratify risk. And again, they reaffirmed the timing hypothesis that there may be risk reduction in symptomatic women who are younger, as opposed to an increased risk in women who are older at the time of initiation of hormone therapy with respect to cardiovascular disease. Now, one thing I do want to highlight here is symptomatic versus asymptomatic. And that is going to be important as we go into the 2022 update, because what we'll learn, and this is kind of the spoiler alert, is that symptomatic women are in a different risk profile for cardiovascular disease compared to asymptomatic women. More on that shortly. So in 2017, the FDA approved indications now for hormone therapy were still hot flashes and prevention of osteoporosis, but now they added for the treatment of genitourinary syndrome of menopause. We learned so much during that time. The FDA was now comfortable with adding another indication for their approval. So now enter 2022. There was continued study on the efficacy and impact of different hormone therapy formulations. And what we learned was that micronized progesterone, which is bioidentical progesterone, and that is, there were plenty of FDA-approved bioidentical progesterone products out there. One of my favorites is Prometrium, but the generic is just fine. Micronized progesterone has a more favorable risk in terms of breast cancer risk than synthetic progestins. So there's been this huge shift toward using micronized progesterone as opposed to other progestins because the data is emerging that there may be a more favorable breast cancer risk profile using micronized progesterone. There was continued study into cardiovascular disease risk. Again, I'm going to get into that in a couple of minutes. And there was also more study into body composition. And what we've learned at this point in time was that hormone therapy has little favorable to no impact on menopausal weight gain. In fact, there have been some studies out there that say that it can be more difficult to lose fat when women are on hormone therapy. It may help to attenuate abdominal fat accumulation in the short term, but the effect is small if there is any effect at all. So when women come to us as fitness professionals and say, I want to get rid of this belly fat, I want to start hormone therapy, it's not the hormone therapy that's going to help with the body fat. It's the weightlifting, it's the nutrition management, the tried and true things that have worked in the past are going to be the tools that we use now to best mitigate body composition changes. So just so you know, it's a big misnomer out there that hormone therapy helps improve body composition, because that's not what the data seems to be saying. Now, the biggest change that came out of this position statement in 2022 was that the long-term use of hormone therapy in women older than age 60 can be considered in people with a favorable risk benefit. So not only have we moved away from 3 to 5, 4 to 7 years from 2012, we have now moved into beyond that timing hypothesis where someone who started menopausal hormone therapy in their younger years, who's doing great on it, is healthy, low risk, if she wants to stay on it at 60, there's no reason she shouldn't. And this was huge, a huge thing coming out of this position statement, because it kind of took the reins off of that definite, you got to stop at 60 or you got to stop after a certain period of time. Doesn't exist anymore. What drives whether you discontinue or continue hormone therapy is based on patient preferences and the risk-benefit equation. So back to vasomotor symptoms and cardiovascular disease. The big thing that's emerged is that women who have a higher frequency and more severe hot flashes are at greater risk of cardiovascular disease. And women with these symptoms are likely the ones to benefit from the risk reduction of hormone therapy because they are at high risk to begin with. So when they take it early on during that safe range, less than 10 years from the onset of menopause, less than age 60, these are the women who are going to benefit the most from a cardiovascular standpoint. When we have other people who are asymptomatic, they're not having hot flashes, but they kind of just want to go on hormone therapy because they think they should. These women aren't going to appreciate the same risk reduction benefits because they're already at low risk to begin with. So as they were discovering this correlation between hot flashes and coronary vascular disease, it kind of made sense of the data, which was kind of mixed before. It's like, why in symptomatic women do we see one thing and asymptomatic women is the other? It's about the risk of cardiovascular disease. So that was kind of interesting, and they're looking more and more into that even today. So again, just the key point here, we use hormone therapy to treat symptoms. We don't use hormone therapy to treat lab values or to blatantly prevent disease in someone who is perfectly healthy and in someone who is asymptomatic. That's not who it's necessarily designed for, but whether a woman is symptomatic versus not is really, really key in interpreting the risk reduction in many of these studies. So body composition and diet culture. Again, this keeps coming up in the position statements, and I have to give the medical community credit for trying. But there is a lot of conflicting messaging. I went to a North American Menopause Society meeting, and I saw one talk of someone basically saying, okay, 1,200 calories a day if you want to lose weight. And, my head nearly exploded when I sat in this lecture. And then I saw one in the afternoon from someone who was amazing, Dr. Fatima Cody Stanford at the Mass General, who really, really got it. She understood what fueling meant, and that, we can't starve people to get them to lose weight, and that just didn't make sense. So there's still a lot of mixed messaging about fitness and nutrition in the medical community. And, at the end of the day, you kind of have to really kind of parse through it all and find your people. And I would definitely recommend checking out Dr. Stanford at the Mass General. And so, what it comes down to is that the medical community just has all that they can do with managing the medical piece. They really fall short when it comes to managing fitness and nutrition and wellness and mental health, with the exception of the psychiatrists, of course. But this is why it takes a multidisciplinary approach. We need our doctors to practice medicine, but we also need our fitness professionals to really lay the foundation so that the therapies and the medical interventions work better. They work better on that healthy foundation of habits than if we have a fractured foundation. The medical therapy just isn't going to work so well. And if she has a solid foundation, she may not even need the medical therapy. So it should be a multidisciplinary approach because it's hard for medicine to really be experts in both. So where we are today, FDA-approved indications for hormone therapy include hot flashes, prevention of osteoporosis, premature menopause, and GSM. Now, this is a cool study that I wanted to raise, and it's all about establishing eligibility criteria for using menopausal hormone therapy in breast cancer survivors. This is a safety report, and this was a really nice meta-analysis, an analysis of several different studies done by a group in Spain, and it was published in the Journal of the Menopause Society called Menopause in 2024, so just last year. The key points, 12 studies, including 3 randomized controlled trials, 3 prospective and 6 retrospective studies. With respect to breast cancer recurrence, the study showed mixed results. Some of them showed a trend toward an increased risk of recurrence in women with a history of hormone receptor positive tumors, but when they looked at breast cancer mortality rates or death rates, they did not find statistically significant difference in mortality rates in women who were using hormone therapy. Now, the authors did put a big asterisk up. They do recommend using caution in interpreting these results because among these studies, there was a lot of variability in the types of hormone therapy that were used, the formulations, routes of administration, and in the patient demographics. There was a lot of variability of who the patient populations were. But this is probably one of the best studies to date that asks this specific question. And it really shows that we need to look at this further because women who are breast cancer survivors, there's a lot of them out there and they're suffering too, and they don't need to suffer. And these therapies may be safe for a subset of them. And even in those who may be at higher risk, well, you know what? It's her risk to take. Our job as medical professionals is to outline what that risk is so that she can figure out what makes sense for her and make that decision for herself. Now, there is another there's another point that that I gleaned from this that seemed to make sense, and that was that, remember we were talking about how there is a reduction in all-cause mortality and reduction in cardiovascular risk in younger population. Well, when we're considering our breast cancer survivor and considering hormone therapy, we have to remember the benefits of hormone therapy in symptomatic women. It's not just all about the breast. She's a whole person and she's got a heart and she's got bones, and we have to consider the benefits of hormone therapy on these other things and not just hone in, tunnel vision on the recurrence risk and the death risk. And it was interesting that in some of those isolated studies in that meta-analysis, the breast cancer survivors who were on hormone therapy were actually living longer than the ones who weren't. And the thought was that in these isolated studies, it could have been this factor, that there is such benefit to using hormone therapy in symptomatic women early on, that those benefits weren't taken into account. So I think that's a huge thing we have to keep in mind when we're trying to figure out what the risk-benefit profile looks like in a breast cancer survivor. And then one of the other things I wanted to raise, this is like the age of questioning dogma now. So this is where kind of the story is to be continued, is that, we've gone from the 1940s where things were just emerging, and now, we're questioning a lot of dogma now that we're learning so much more about risk profiles in women with breast cancer. Dr. Susan Davis, who is a well-known researcher in Australia at one of the premier universities there, wrote a beautiful editorial and a very compelling case for why we should consider initiating hormone therapy in select women beyond age 60. So, we've had this timing hypothesis that stood the test of time for 20 years. Dr. Davis is calling that out now too and saying, hey, we got to look at this also. So it's a very exciting time to be in the hormone therapy field and watching this story continue to unfold. So just in summary, it's an individualized approach. Every woman is different. There's been huge expansions in knowledge about hormone therapy since the Women's Health Initiative studies came to be. Evidence still does not yet support the use of hormone therapy for disease prevention solely in asymptomatic patients, except in the case of preventing osteoporosis. There is strong evidence for long-term support for HT use in women with premature menopause. Transdermal preparations are still favored because it is believed that the risk profile for blood clots is lower. And hallelujah, there are no longer any recommendations for set limits on duration of hormone therapy use or age of discontinuation. And with that, I thank you all for your attention. I am seeing patients via my telehealth practice. I am licensed in Massachusetts, New York, New Jersey, Ohio, Florida, and the great state of California. You can book appointments with me through my website. And if you are not part of these states, I do other consultations too. I do performance consultations, health and wellness consultations for those of you who are not in the states I'm licensed in. So again, thank you for your attention today.
Awesome, everyone. I'm going to leave. I'm going to ask Carla to leave that slide up for a moment, just in case any of you want to grab her information to connect with her on the various social platforms, but also her athletic aging blog as well, and then her website there, Dr. Carla D at drcarlad.com, and just make sure everyone grab that, because once she turns that off, we don't have it in the closing slides. So I'll say going once, going twice, going thrice, and done. We're going to move over to looking at the closeout, and let's pull up the questions panel. There's a good one already sitting in there. There may be a few more. If you do have one that's come to mind, be sure to drop it in there. And so that, okay, Carla, here we go with the first question for you.
Mm-hmm.
This is from Amy, and she's asking, if you have a patient who doesn't want to use synthetic hormones for various reasons, what natural therapies do you recommend, allowing, of course, that we're assuming there'll be some dietary changes in fitness, so she would go kind of beyond that. Like, what other natural therapies would you recommend?
So by natural, I'm assuming non-pharmaceutical. Is that correct, Amy? Non-pharmaceutical?
So wait for her to drop in there. She can't say anything like
Oh, right, because she's
everybody's
okay.
automatically.
Okay, I'm assuming she means non-pharmaceutical.
She
I
says
mean,
yes.
yeah, my approach
Yeah,
to
she said yes.
is the first thing we have to figure out is exactly what is she experiencing and what are all of the circumstances surrounding that. And so my approach is to build the foundation first. If she is having trouble sleeping and I find out that she is having a 24-ounce coffee at 7 p.m., we're going to work on those lifestyle habits first. You got to build the foundation. And then, if you make lifestyle changes, if you make, certain changes, depending on what the symptoms are, if she's still not getting adequate relief, then we can move forward and say, okay, maybe an estradiol patch is something you might want to do, or maybe if you don't want to use hormones, you can use other non-hormonal pharmaceuticals. But depending on what her symptoms are, her experience, and her circumstances, I start from the ground up. And medication and pharmacology is really kind of at the top, where that's on top of the foundation that we strive to build first.
Okay, good answer. Okay, Lisa, who I think you know very well, has asked a question here. She says, can you address the use of testosterone for women along with estrogen, estradiol, and progesterone?
Sure, Lisa. It's great that you joined us. So there is some really good data that has longitudinal reach of about 4 years or so, that ideally transdermal testosterone, but people use pellets too. But the studies, most of them are done with transdermal cream testosterone, is very effective for low libido in menopausal women, and there's more data emerging that it can be helpful in perimenopausal women. And the target that you want to make sure, first of all, you want to make sure their symptoms are relieved, but you also want to make sure that their testosterone levels in their blood remain in a safe range. The safe range is the physiologic range for a reproductive age female. And in America, the usual convention is between 20 and 80 nanograms per deciliter. In the UK, they use picomoles per liter or something like that. It's a different convention in the UK. But in America, that range is usually 20 to 80. If you can keep people within that and keep them feeling good, very, very safe to use it for at least 4 or 5 years. Beyond that, we don't have a lot of safety data, but there's a lot of good short-term safety data for low libido and even just low drive in general. I find that when I put people on it and keep them in that safe range, they feel pretty good in a lot of different things, not just the libido. So I prescribe it pretty liberally, but I just make sure that I keep it in the safe range.
Okay, Good answer. Okay, Kimberly's asking, I've been on oral hormone therapy for 2 years. Is it safe to just switch to transdermal at this point?
Yes, it absolutely is safe. Obviously, before you go off a medication, you want to check with your doctor and just make sure that they transition you properly. Depending on what you're on, they may want to wean you, or they may want to just transition you. But however your doctor, whatever exactly you're taking the hormone therapy for, it is safe to move to transdermal for sure.
Okay, there's a lot of stuff in the questions panel. This one's kind of long. I'm going to try to summarize this. This is from Cheryl. She's 66 years old. She's not used any hormones or birth control pills for hormone therapy. She's two sisters and a mother, all who did, and they all three had malignant breast tumors and hysterectomies. Possible
Mm.
coincidence, but nonetheless, she's hesitant to explore taking hormone therapy, believing that her risk for cancer is increased. She's
Yeah.
very active, eats a good diet. Fitness has been a lifesaver. Looks like she's a veteran. It's all or nothing at the particular VA hospital she goes to. She wants to explore natural and alternative options, and she's currently studying oncology massage and is wondering how lymphatic drainage massage can help increase the opportunities to eliminate waste products in the tissue.
I am a huge fan of lymphatic drainage and massage. I do it myself for maintenance. When I recently made a big cross country move and I was without it for a little while, and oh my God, did I miss it? I'm a huge fan of that. And yeah, I mean, it depends on, what symptoms you experiencing will determine, what natural interventions you pursue. But specifically, massage and lymphatic drainage, I love it.
Okay. Good. Just getting a lot of thank yous in here, trying to weed those. Everybody's saying great information. Thank you. Let's see. Chris is asking, wonderful talk. Any suggestions for a 60-year-old losing hair at a rapid rate? Been on hormone replacement therapy for 15 years. No prior issues with hair loss or thinning hair.
I would have your thyroid checked. Definitely see somebody for that, especially if you're losing hair and you have bald spots. There are many different causes of alopecia, but you definitely want to be evaluated for that. Thyroid is usually the first thing we check, as well as sitting down, taking a thorough history to see what else is going on.
Okay, very good. Just going to give you a little shout out. Kenrick is saying, thank you, very informative. Love the idea of expanding knowledge to help our clients as the unique individuals we are. Yeah, it can really sort of give you a little high five there too while I pull up the next question. It's there's so much nuance in all of this, and it's so infrequently found. And I think that's one theme through your talk today was there's a lot of nuance in this, and everybody has to treat their situation individually. Andrea is asking, she has two questions on progesterone. One, if on estradiol, should progesterone be 30 days per month, or can it be just the last half of the cycle? That's question one. Question two, she heard recently that progesterone has been tied to an increase in breast cancer. This was actually from my last appointment at her gynecologist. So do you need me to read both questions again, or you got them?
No. They're excellent questions. So here's the beauty of why I love to separate out the patch and the pill, is because you can use progesterone many different ways. So if I have a woman who's having hot flashes and it's really interrupting her sleep, she has terrible sleep, I'll use progesterone. And this isn't a menopausal woman who has no more cycles. Okay, that this is that you treat the perimenopausal ones different than the menopausal ones. In someone who's menopausal, I like to give the progesterone every night in someone who has difficulty with sleep, because the progesterone, along with some magnesium, can be very helpful for sleep. Conversely, if I have a woman who has a lot of side effects with the progesterone, she's got breast tenderness and bloating. For her, she sleeps fine. I could just cycle that progesterone 7 days a month to protect, because it really is just to protect the uterine lining. That's the major reason why you give it. And it doesn't have to be given every night. So in the person who has side effects, I might cycle it, 7 days a month. You could even skip a month. As long as the uterus is seeing about a week's worth of progesterone every 3 months or so, that will maintain that low risk of endometrial hyperplasia and cancer. So there are many different correct ways to use the progesterone, and I use it depending on what their circumstances are. Regarding the second question about correlation with breast cancer, I haven't seen a lot of data on that. There may be a study out there. I haven't seen it myself. I would be interested in reviewing it, but I haven't seen that theme emerging in any of the literature that I'm reading regularly or in the position statements so far.
Okay.
Except for progestins, the synthetic ones, Depo, like Provera, which is medroxyprogesterone acetate, those synthetic ones have been associated with a higher risk of breast cancer, but micronized progesterone, to my knowledge, has not been associated with that.
Okay. Very good. You're knocking these questions out, by the way. There's a higher than average number of questions in here, and I guess it's the
I'm
complicated
glad I
nature of
didn't put anyone to sleep. I was worried I was putting people to
it.
sleep. You
Far
don't
from
present
it.
live, you get no feedback from the audience, and so I'm
No,
like, everyone's
this
sleeping
is
for
a
all I know.
this is a topic that affects everyone in the fitness industry. I'm disappointed I can't listen to your answers to question as much because I'm trying to read the next one. So I'm kind of like wanting to listen to your answers, but I'm not able to grab them as much. But so Lanita is asking, she said, thanks for the great presentation, but to clarify, I think you said hormone therapy is indicated in women with premature menopause to decrease risk of coronary artery disease, but this seems to contradict the fact that MHT is not prescribed for this in the menopausal female because the research is still equivocal. I guess she just wants you to clarify that.
It depends on, first of all, women with premature menopause before the age of 40, it's a different animal. These women lose their estrogen, a good 10, 15 years before they're supposed to. So one of the big things that we noticed in women who never got that, or in women who they removed their ovaries for no reason, okay, take the uterus and the ovaries too, they had a higher risk of developing cardiovascular disease. So we find that it's protective in these women because it is hormone replacement therapy in this case, because we are replacing something that is supposed to be there. Once a woman hits menopause, nature now dictates that, okay, we're dialing down cycles. Estrogen really isn't supposed to be there anymore from a natural standpoint. And so when we're at that point in our life, our risk profile for coronary artery disease is different, much, much different. And then in that population, that older population, we find a difference between symptomatic women, meaning with hot flashes, and asymptomatic women. And in asymptomatic women, the results are equivocal whether you're going to reduce any risk, but in the symptomatic women, there seems to be more risk reduction to be had. So it's really comparing apples and oranges when you're comparing one age group to the other, because women with premature menopause are a completely different medical entity.
Okay, good. Doing a great job with these answers too. Good information, but also brief enough we can get to more questions.
Yeah.
Kathy's got one here. What are your thoughts on a woman using oral progesterone after a hysterectomy?
Oh, I do it sometimes in women who are having difficulty sleeping, because progesterone, can work pretty well for hot flashes and sleep. So, generally we give progesterone to protect the uterus, but it has other uses too. I've used it in women without a uterus, and it can help them, especially if they prefer not to use estrogen for whatever reason.
Okay. Carrie is asking a question. She's also saying that you know her too, and she's working her way through your course. So she just wanted to pass on a hello there. She says, you mentioned having hormone therapy, no significant effect on abdominal fat accumulation. Was this just with estrogen and progesterone studied, or have there been any studies on the use of testosterone? She put T. I'm assuming that's what that refers to.
So the interesting part of the question is about testosterone. In estrogen, in hormone menopausal hormone therapy, standard estrogen progesterone therapy, I don't think the studies have really parsed out, attenuation of body fat in estrogen alone versus estrogen plus progesterone. I think they've looked at, mostly people with estrogen and progesterone because, most people have an intact uterus. And there just doesn't seem to be a huge impact on it. Like I said, there's some studies that show a mild attenuation. There's other studies that show that maybe it's harder to lose abdominal fat. When it comes to testosterone, there was one really good study that I saw that showed different doses of testosterone and testosterone levels and how they correlated with increases in lean muscle mass. And you have to be taking almost male level testosterone to be able to see those significant differences in muscle mass. But when you are above those female physiologic ranges, your risk of side effects becomes much higher. And also, you have to worry a little bit about insulin resistance, because when we have more androgens or testosterone like male hormones in our bodies, that tends to put us at risk for insulin resistance. Polycystic ovarian syndrome is a natural example of this, where women with hyperandrogenism, naturally, they've got more, testosterone than they should, have a real struggle with insulin resistance, diabetes, and metabolic syndrome. So we try to avoid those ultra high doses of testosterone because of the risks that go along with it. And unfortunately, those are the only doses that have shown an impact or a significant difference in body composition changes.
Okay. Francine has a question. She's asking, what are your thoughts regarding declining estrogen and coincidental decrease in elastin, increasing the incidence of soft tissue injury, such as strains and sprains?
Oh, it's all tied together because most tissues in the body have estrogen receptors. So you got a hormone, that hormone has to talk to the tissue somehow. And the way it talks to the tissue are these little proteins on the tissue called receptors, like a lock and key. The hormone connects to it, sends a message to the tissue, and the effects happen. So tendons, ligaments, skin, all of these tissues, the brain, the bones, the muscles, all have estrogen receptors. And so when estrogen levels decline and cycles are becoming more infrequent as perimenopause and menopause continues, those messages are more infrequent and you see changes in those structures. So we see that reduction in skin elasticity. We see joint laxity. It's correlated because all of those tissues are looking for estrogen signals that they're not getting in that stage of life, and then the tissue changes.
All right, Andrea's got another question. Her main menopause issue is terrible sleep, not related to hot flashes. Does hormone therapy help for this?
So this is interesting. I came across an interesting study about people who had, I forget what the name of the study is, somnography or something, where you put these electrodes on when you sleep. They do it with sleep studies. And what they noticed was that people who stayed asleep and didn't wake up or perceive hot flashes actually were having vasomotor symptoms picked up on the electrodes. And so what happens is that these occult hot flashes that you don't know you're having and aren't waking you from sleep, they are disrupting your sleep because you can't get into that deep sleep or REM sleep quite as efficiently. So sometimes hormone therapy can help because it will reduce those vasomotor symptoms, even if you're not perceiving the hot flashes during sleep. So I would try it in somebody, assuming that they're a low risk candidate, because those occult vasomotor symptoms do occur and can be significant in disrupting sleep.
Yeah, interesting. I guess with a lot of your sensory system turned off during sleep, you may not notice you're getting the hot flash.
Yep.
It may not be something you're consciously aware of.
Yep.
Lisa's asking another question. How do you determine how much of each hormone you need to be on, and how do you monitor it?
It depends on what the hormone therapy is that I'm prescribing. With testosterone, I always check total testosterone levels in the blood to make sure one is in a safe range. For estrogen, progesterone therapy, it's titrated by symptoms because we know from years and years of study that a woman's experience correlates very poorly with her lab results. How many times do women go to their doctor? They feel like they want to jump off the roof because they're experiencing all these symptoms. Doctor says, oh, your labs are normal, go home, you're fine. How frustrating is that? It's because there's so much going on under the radar of the serum blood test. So when it comes to estrogen and progesterone therapy, I start with, a standard dose and see if it works. If it does, that's great. If it doesn't, I might try a higher dose. If I suspect that one is not absorbing it, I will do a level to see if she's absorbing it. If she's not, I'll try a different mode of administration. So with estrogen, progesterone, hormone therapy, it's all about the symptoms. It's all about how she's feeling. That's my end point. But with things like testosterone, it's about how she's feeling, but she also has to be in the safe range as well.
Got it. Excellent. Okay, Stacy. Stacy has a question. How would hormone therapy assist a woman with Hashimoto's disease? She's perimenopausal and just recently got diagnosed with Hashimoto's. Her gynecologist mentioned it, but has yet to prescribe anything until her next TSH level test.
Well, we don't usually use hormone therapy to treat Hashimoto's. You know, Hashimoto's is a funky disease. I was just talking about it to a patient this morning, that you can have a Hashimoto's flare and you can be hypothyroid for a while, and then it sometimes resolves itself and thyroid function returns to normal without medication, and sometimes it doesn't. These autoimmune diseases are tricky. Estrogen therapy, progesterone therapy, you know, it's still very muddy how these therapies impact autoimmune diseases. We don't really know a lot about that. There hasn't been a ton of study on that. So it's something that's very individual. We don't usually use it to treat Hashimoto's, but you know, the jury is out whether it helps or doesn't help autoimmune type diseases.
Okay, awesome. Well, that I think has to be a record for the number of questions we got through. Thank you for allowing ample time for that. It's good.
Anytime.
There's often a lot of questions we can't get to, and you did a great job both answering them with quality and also just enough brevity to get to more questions. So thank you for that. We got through all of them unbelievably. So everyone, be
Great.
sure to grab the info on the screen. I'm also going to send it to you, but also in the PDF of the slides that Carla made for you. I'm sure that last slide will be in there. If you want to follow up with her and maybe get a consultation for yourself or for a client, you could reach out to her through that as well. If you didn't get a chance to grab it earlier, that closing slide will be in the PDF of the slides that you have. And I think you can tell that she both knows a lot and cares a lot, which to me is like a winning combination for any professional. So be sure to reach out to her if you need her help in any way. And again, be sure to take advantage of the discount on the course that we're offering. It's the biggest discount we offer on any course, 50% off. So be sure to grab that. It's available until January 24th. And I'm going to turn it over to Carla just for any last close, but I'm going to say my goodbyes to everyone now. So thank you for giving us the gift of your time and attention and your energy today, and hope it was valuable. And it sure was for me. I'm going to probably have to rewatch to listen to the answers to the questions. But Carla, over to you for any closing thoughts you want to share with everyone, and just wish everyone a great rest of the day.
Well, I'm just humbled by the number of people who registered for this seminar today. Lisa was sending me updates by email of how many people registered, and
It was
I'm
up to almost
humbled by
400 by the time we started today. So yeah, it was 340. I think I said it was about 340 yesterday. We hit almost 400 by the time we started today. So good.
Yeah, I mean that's amazing for me, and I'm just so grateful and fortunate to share your journey as providers, as patients, and you know, I look forward to doing more of these and hopefully connecting with many of you.
Awesome. Thanks, Carla, and thank all of you once again. Have a great rest of the day.
Thanks, Jonathan.
Mhm.